So this is a short suturing video. It's the first time I've used my head camera for it. I didn't have a good suturing pad or a professional one, so I sacrificed this citrus fruit. That I think is a 2.0 silk suture. The orange peel doesn't handle like human skin, of course. Apologize for that. I did the best I could. This first one is a near-far suture, a running suture. I very rarely use it. I prefer interrupted sutures on people. Running sutures are fast, they're easy, but if something goes wrong with the suture, you lose the entire suture path. If somebody gets an infection post-op in one suture, you can't just take it out. You've got to either tough it out, give them antibiotics, or take out the whole thing. And then you have a wound dehiscence. So I almost always use interrupting people. I'm too nervous to do running. But a lot of people use running, especially in something like a carpal tunnel. So the idea with the near far is that you place one suture close to the edges of the skin in order to align the skin edges perfectly, and then you put the next suture far and far on both sides in order to get more holding power and grab more skin. So essentially what you're running is a kind of a mattress suture where you have a too near and too far, except you're doing it in a running fashion. And when you do it this way, a far and a far and a near, it comes out looking like the seam of a baseball. One is high, one low, back and forth, and that's just if you alternate the two. And of course you're not going to see it so dramatically on this one because I'm having a little trouble handling the skin edges of the orange with my adson. When I tried to grab it, they broke apart, or I just can't evert them. That one cut completely through because it's very flimsy, not like skin, which is more like leather. So I'm doing my best. Hang in there. Yep, again it pulled through. Should I have edited these? Trying to get a good placement, sorry. I may have hit a pit or a lymph node, who knows. So when you first tie it, of course, you have to put one loop in and tie off. Then once you've tied off, you can go with your, near, far, far, near, far, far. And eventually you wind up looking the baseball stitch. I'm trying to exaggerate it a little bit, and you can already see it. It has that kind of staggered baseball seam look to it. If you don't believe me, just try it for yourself. You'll see. And I'm running out of suture here. That was one I had used before for a practice, but I tried it in the foam and it didn't work, so I resorted to orange. And then unfortunately I leave myself with a very, very short amount of suture at the end to tie off the last knot. But you see a little baseball stitch there? See, back and forth? You get it? I think I didn't have adequate anesthesia for this orange is part of the problem. And then you tie it off. You have to leave a loop sticking out. You can't obviously pull down the last one. You have to have a little loop of suture so that you can tie it off. And there it is, and then you snip off the ends, and you're done. There's a near, far, and an orange with I think a 2.0 silk. I hope I didn't adjust myself out of the field there. Okay. Now I gotta go get more suture material. This I will cut out. So these are practice sutures. I got them on Amazon for some incredibly low price, and when I opened them, they are identical to the sutures that we use in the operating room. They have the double sterile package to them. They have expiration dates on them and manufacturing dates on them. The manufacturing date is something like last month, and the expiration date is years from now. I guess they're simply not certified for human use in the United States, and so they sell them for something like 25 cents a pack. I mean, there's 40 sets of sutures in there, probably normally cost about $400. And I think I got them for $11 for all of them. So you can use them for practice, or if the people you're suturing don't mind having some European manufactured suture, But they look good to me. I'm sorry this one is so small. I wanted to have a smaller, finer needle. I hope you can see the thread. It's really is hard to see. These are some sutures that I like to use, especially in something like where the skin is a little thicker. This is a horizontal mattress. You can make one towards you and one away from you. I'm sorry that you can hardly see the suture here, but you will get the idea in a minute. You pull it through till you get just a little bit on the end so you can tie. Changing my hand position. And then you put one through in the other direction. You space it apart a little bit. And pull the needle out. Pull out your slack. 2 wraps for the first pass. Pull it down. Can't pull too tightly. It's only a 4-row suture. It's very small. And single wraps for the rest, and usually I do about 6 knots. Pull the knot down. Now reverse your wrap to make your next knot. I forgot the scissor. Got the scissor, cutting the sutures. I'm sorry it's so faint. So that was a horizontal mattress. The next one's going to be a vertical mattress. And first you take a far throw. Trying to make a far throw with that little itty bitty baby needle. I think I see a little bit of the tip coming out now. There it is. I'm going to inch it out. Pull it through till you got a little tail on the end, so you don't use up too much suture with each suture material with each stitch. And this one you put very close to the edges, and the idea is to align the edges very carefully. This is something you often use when the skin is very thin, and if you put the stitches far, the skin just buckles one underneath the other when you pull it tight, and you can't have that. You want the dermis to match the dermis. So you have the far one for holding power and the near one for alignment. And this is a vertical mattress, and it does it all in one stitch. And then you make your ties, 2 passes, 2 loops for the first, a single for the next, and you alternate the direction of the loop so that you get square knots instead of slip knots. And then you get your trusty scissor, or ask your assistant scrub nurse to do it for you, scrub tech. And there you have a near far, a horizontal mattress, and a vertical mattress. And now we're going to do something that's really important to know. This is a crack house suture. And this is something if you were suturing a tendon and you really needed a very high pull-out strength. So you would do a locking suture. So the suture coming in from the right, that's to simulate you putting the suture into the end of the tendon, the kind of mop head end. Then you start to make the passes horizontal. Easier said than done in an orange. And then you loop the suture over it so that you have kind of a retained loop. And you keep going this way. It's very tedious, but it works very well. Popularized by Dr. Krakow, who has tested it in the lab. And if you want to watch a really good suturing technique, just go on YouTube and look up how to do a Krakow suture, and somebody with a heavy suture and on a better demonstrator than me will show you one very nicely. And you go sideways, and then you bring the loop over and the needle through it so that it locks. That's a locking suture. Then you do the same thing on the other side, and they say kind of the trick to it is to keep going in the same direction, and it seems to work out. And then you pull the back loop up over your needle and put your needle through, and then you start going down the other side. And what you normally would do is you would do this on one tendon. Let's say it's an Achilles tendon or a patellar tendon. Well, let's say an Achilles tendon, it's ruptured in the middle. So you put this through on one end, and you have the two ends then, as you will see, coming out the end. And you have this locking suture. Of course, for that, you'd use a very heavy suture, like a suture tape, an Arthrex suture tape, or a number 5 Ethibond, or some super heavy suture. And it goes through the loop, so it locks. It's a locking suture. And then on your final pass, you just go out the end. And the place where you go out the end has to be the part of the tendon which is going to abut the other tendon. So it usually is a little further back than the mop head end. Otherwise, you won't have enough room. And now you have two sutures hanging out the bottom. And then you do the same thing on the other side of the tendon, the proximal end, the distal end. And then when you're done, you hold the tendons together by, say, extending the foot, plantar flexing the foot, and you tie one. You have somebody put a clamp on it so it doesn't loosen. Then you tie the other, clamp it, and then tie it. And okay, here's our close-up. Now you can see the sutures a little better.